Hello, everybody. First of all, thank you for the invitation and thank you for this organization, for the organization committee. I'm from Istanbul, Istanbul Florence Nightingale Hospital. I am an interventional radiologist. And my colleague here, Dr. Cüneyt Türkmen, he is a nuclear medicine specialist. But our surgeon, transplantation surgeon, Dr. Yaman Tokat, apologized for everybody for not joining us today because of her, because of his excuse. So I'm gonna talk about the comprehensive liver center in our hospital a little bit. Then, as an interventional radiologist, give the lecture as a case-based discussion of liver tumor treatment. What one should have, or what we have to be an comprehensive liver center. So first of all, you should have academy or an organized hospital with a science team and with a multidisciplinary tumor board. Multidisciplinary tumor board, I think, the most important part of the comprehensive liver center. In our hospital, we have liver transplantation center and over 100 liver transplantation in a year, and mostly advanced cases. And we have surgical oncology also, and we have the options of robotic and laparoscopic oncosurgery and intraoperative interventional radiological treatment options. And we have also radiation oncology with true beam, cone beam CT, stereotactic radiosurgery, and gamma knife. And in medical oncology, systemic chemotherapy, immunotherapy, and targeted therapies is established. And in radiology, CT, 3 Tesla MRI, PET MRI, and interventional radiology, biopsies, biliary drainages, tips, and as an interventional oncology, radioembolization, chemoembolization, and RF ablation also. So we have nuclear medicine department with PET CT and PET MRI. We are doing radioembolization together. And our multidisciplinary tumor board meet weekly as a multidisciplinary tumor board, especially in liver cancer patients, and over 20 cases in each joint. And we have a technology of multimedia connected internally and externally, and to give enough time to every case, of course. So how we set up? The first thing, I think, the setup with academy and science. And then with academy and science, we obtain technical success, clinical success, follow-up, data collection, research paper, industrial support, and be a center of excellence, any part of the team. And these successes are also affect technology and bind with industry, and then with economy and cost-effective issues. One should think how to set up a comprehensive liver center. As a comprehensive liver center, as an interventional radiologist and interventional oncologist, we began to be a center of excellence in the treatment of liver tumors with radioembolization. And the first time in radioembolization, the Chicago is the center of excellence, and then in Europe, in Germany, Essen, and then we became a center of excellence with in the treatment of radioembolization of liver tumors in 2016. And this is our certificate for the radioembolization center of excellence. And you saw the other center of excellence in the world. 3 of them is in United States, and two of them Europe, and one of them Florence Nightingale Istanbul Hospital, and two of them is in the Far East. So interventional oncology is a subgroup of interventional radiology. And in interventional oncology, we treat liver tumors, renal tumors, bone tumors, lung tumors, and give another palliative treatment to all kinds of cancer patients. And interventional oncology, we are doing especially chemoembolization and radioembolization in the liver tumors, and RF ablation and microwave ablation in renal tumors, liver tumors, and bone tumors, and biopsies and drainages. So, if the localization, size, and number of the liver lesions, metastatic or primary liver cancer, is not suitable or not amenable to RF ablation or microwave ablation, what we do intraarterial treatments. In the beginning, intraarterial treatments begin with only the blunt embolization. Blunt embolization means that use particles, embolization particles, and do devascularization and ischemic only. And soon, classical TACE and depth TACE are developed. In classical TACE and depth TACE, we mix the particle material with chemotherapeutic agents, and in depth TACE, spatial chemo-loaded microspheres we used. But in the last 10 years, the new technology is, I think, radioembolization. In radioembolization, there will be minimal devascularization and ischemia, and there will be no problem of VEGF, I think, because of there is no ischemia and maximum tumoral penetration. We especially and generally use radioembolization for the advanced case of liver tumors. As I mentioned, in chemoembolization, we use doxorubicin or irinotecan loaded microspheres, and in radioembolization, Y90 loaded microspheres. And I want to show some cases of us for the chemoembolization and radioembolization. This is a chemoembolization of a HCC, and after chemoembolization, there is little residual lesion in the liver. So this case is a young man with a huge tumor at the segment 4 and segment 1 and segment 7. You saw the lesion located at the neighboring vena cava inferior and hepatic vein junction. This is the axial plane. You saw the multilobulated big lesion, approximately bigger than 10 centimeter. As this is the angiography, you saw pathologic neovascularization. During the angiography, we always do COMBEM CT. COMBEM CT is a spatial CT examination that we do during the angiography procedure. It's done by angiographic device, and you clearly saw how many tumors and the location of the tumors. As this patient, you saw on the MRI section, MRI images, the huge lesion, but there are also small, multiple satellite lesions in this case. So it's an advanced HCC case, multiple HCC case. So we think we start with radioembolization because the number of and the size of the lesion, we didn't prefer chemoembolization. And then, pardon me, and then 2 months later, you saw pre-radioembolization images and post-radioembolization images, and 2 months later, there was a partial response for the HCC and a drop of AFP level. And 3 months later, as there is a portion of segment 4 tumor component, we super selectively reach the segment 4 artery and do the cone-beam CT again. You see the left side of the tumor here, and do an super selective radioembolization. And then 6 months later, the tumor is totally necrosed by the radioembolization, and there is no contrast enhancement, and the AFP level drop from over 400 to 4.4. And then 10 months later, you see there is no progression or recurrence lesion in the liver, so the tumor are still totally necrosed, and the vena cava inferior is free from compression, and the AFP level turns to normal. So this patient may be downstaged to transplantation or any resection, and the biochemistry results are also normal. This is another special patient and interesting patient. He's a man also, and in the MRI section, T1 weighted contrast enhanced sections, there are so many lesions, all of the segments of the liver, and they are conglomerated, and so there was main and right portal vein tumor thrombosis with enhancing also, and left portal vein thrombosis. And at PET-CT, the portal vein tumor thrombosis take FDG. So we plan to treat it with radioembolization because it's an advanced case. This is an angiogram. You see the right and main portal vein tumor thrombosis enhancing in angiography, and this is left portal vein tumor also seen in the angiography. And after 6 months of radioembolization, there is some residual tumoral tissue in the liver, but most of the HCCs are respond completely, and then you see the left portal vein with necrosis, and right and main portal vein with necrosis with cavernous transformation. And after 10 months, there is some little HCC foci, and the left portal vein also still necrotic, and the right one is necrotic and fibrotic. And after 17 months, there is no residual HCC foci at the liver, and the portal vein tumoral thrombosis are totally treated with radioembolization, and there is some atrophy of the left lobe and right lobe also. And 20 months, nothing with HCC and portal vein thrombosis. And after 20 months, you see the response, and this is interesting that the proximal part of the portal vein is open, with the distal part with fibrosis, and the response is very well seen with pre-radioembolization PET-CT and post-radioembolization PET-CT. Now, we asked this case to our transplantation surgeon that could you please transplant it, and could you steer the portal vein, this open portion of the native portal vein, and they are planning now. This is another case of HCC. There is a small nodule at the segment 2, and there is a huge HCC at the right level of the liver with segment beginning segment 8, 5, and some 6. This is the MRI examination of the huge lesion. So this is the PET-CT examination of the case, and we did angiography. There is a replaced right hepatic artery originating from the superior mesenteric artery. You see the hypervascularization, and you see the pathologic neovascularization. Also, always we done combium CT. You see the localization of the lesion. This is the arterial phase. This is the venous phase. So we plan to do radioembolization and microwave ablation combination for the small segment 2 lesion. We did the microwave ablation during the Y90 radioembolization. You see US guided microwave ablation, and immediately after ablation, at the angiogram, you saw the dead space of the ablated small segment 2 lesion. So after 2 months, the huge lesion regressed significantly, as you see, and after 4 months, there is a triangle shaped, just like a metastasectomy resection location. Total necrosis by the radioembolization, and significantly tumoral size regression. So after 4 months, you see the result, and the biochemistry is normal, and then also this case is successfully downstaging to transplantation, and our transplantation surgeon planning to transplant these patients and attend these patients in their list. This is a young lady, centrally located huge cholangiocarcinoma. This cholangiocarcinoma is near the drainage of the hepatic veins to the superior inferior vena cava. You see the left, middle, and right hepatic veins. Middle and all the hepatic veins are invaded by the huge tumor. So this is a contrast-enhanced T1-weighted MRI scan. This is the PET-CT scan. So this is the angiogram. You see the pathologic neovascularization and displacement and stretching of the arterial structures. This is right-sided, and this is left-sided portion of the lesion. So this is a right-sided portion of the lesion, combium CT, and left-sided portion with combium CT. So this is the left-sided. This is a variative gastric branch. We embolize it, and this is the segment 4 portion of the lesion. So after 4 months, there is a huge necrosis in the lesion. you see the left hepatic vein, and there is a contrast enhanced segment 7 component of the lesion, you see. And then 4 months later, there is some metabolic partial response for the cholangiocarcinoma, and the CA19-9 is dropped 3 times. And at 6 months, the metabolic response increases. And then after 6 months with MRI, we also see the segment 7 component is contrast enhanced. So we plan another radioembolization for the segment 7 only. This is the beginning, and this is the post-radioembolization angiogram. You see that all the normal feeders, arterial feeders, are open. This is the different from TACE. Radioembolization don't occlude the arterial feeders, and there is the mass effect is disappointing, dissolved, and this is the super selective at 7 segment 7 artery. So we locate the segment 7 portion with common CT. You see the lesion only in segment 7. So we are planning to do radioembolization only in segment 7 portion of the lesion. You see the pre-radioembolization, and 7 months later, it shrink this lesion, but segment 7 portion is active. This is subtraction mode. There is no contrast enhancement in the lesion except segment 7, and we super selectively give MAA test and make a Y90 radioembolization only in segment 7. So after 10 months, this is the beginning, and after 10 months, you see the huge lesion shrinkage with a reduction of volume in more than 50%. And you see the left hepatic vein drainage to the vena cava inferior, and this is the distal portion, and some necrotic tumor tissue behind the left hepatic vein, but our surgeon said that now we can operate this patient, central located cholangiocarcinoma. And I think this next week they will operate this young lady. So it is a successful downstaging of a huge cholangiocarcinoma to resection and surgery. Nowadays, the premier clinical trial has ended, and the results are very well. In downstaging of HCC to transplantation and resection, radioembolization is superior than TACE. And I think in the future, in cholangiocarcinoma, we will get same results, I think, but data, we are waiting for data. So we are doing radioembolization, not only the primary liver cancer, also the liver metastasis. This is a breast carcinoma, disseminated metastasis in the liver. You see the liver lesions, liver metastasis at the late phase of the angiogram. We did radioembolization for this patient for a palliative manner. So you see the metabolic response, pre-radioembolization and post-radioembolization. This is an interesting case, single colorectal metastasis, small and single metastasis at the left lobe, at the falciform ligament. Normally, we do RF ablation or microwave ablation, but it's near and at the falciform ligament. So the patient's condition, general condition, is not suitable for the metastasectomy surgery. So we did radioembolization again with super selectively interlesional radioembolization, and the metabolic response is very well. This was a multiple colorectal metastasis of the liver, and under the chemotherapy treatment, there was very significant progression. Yeah, you see the lesions, and this is a chemotherapy refractory patients. So we plan to do radioembolization, and after 7 months, you see the metabolic response. This is a single metastatic breast carcinoma lesion in the liver. It's a subcapsular location. So because of subcapsular location, we didn't prefer to do RF ablation or microwave ablation because of complication and very high recurrence rate of this kind of localization, metastatic localization. And you see COMBEM CT, it's subcapsular, and a very vascularized lesion. And this is a pre-treatment PET CT and pre-treatment T1 weighted contrast enhanced MRI section. With it, you see the super selective radioembolization, but not interlesional. This is breast carcinoma metastasis. Around the lesion, we can radioembolize around the lesion. Also, as you see this, the surrounding arterial feeders. So 2 months later, there was a black hole in the MRI, totally necrosed lesion, and also the around the normal parenchyma. So this is another breast carcinoma single metastasis. It's we said that it is subcapsular. So we conclude and we verify it with COMBEM CT, and you see the subcapsular location of the lesion, not amenable to RF ablation or microwave ablation. So we did super selective radioembolization in this case again, and after 2 months, you see the small residual lesion, and after 4 months, all the lesion and this segment is totally treated with radioembolization, super selective radioembolization. Thank you for your interest.
Thank you very much, Professor Murat Cantasdemir, for this very interesting presentation and for those fascinating cases. I have a very practical question. We have a very similar platform for liver disease, liver oncology, and such sort of problems in Fundeni Hospital. And in our platform, the patient for this kind of interventions is admitted in the Department of Gastroenterology and Hepatology, because previously we usually make a band ligation of the esophageal varices, and then the surveillance is in a gastroenterology department. So my question is, where is the place of the gastroenterology in your platform, the gastroenterologist?
Yes, we have gastroenterologists also.
All right.
They treat the patients for the viruses, hepatitis viruses, and they work for follow-up, and they work for the medicine administration for the patients.
So the patient is admitted in the radiology department for this procedure?
I understand you, yes. In the beginning, as an interventional radiologist, I want to set up the multidisciplinary tumor board, because I think that interventional radiologists may be more objective than clinicians, gastroenterologists, surgeons, and another clinicians. Then I made a plan that if I set up this multidisciplinary board, all the clinicians I can join in the same table with an objective manner.
I understand. Thank you. Other questions? Adina, please.
Thank you very much for this case presentation. And I have two questions. Which were the adverse events for this patient for this type of therapy? Adverse events.
Yes.
Early adverse events and later adverse events.
All radioembolization is a well-tolerated treatment modality. The adverse events is some degree of fatigue, some degree of abdominal pain in the first 2 weeks. Except these small, minor adverse events, there is no major adverse events in the radioembolization treatment if one can do proper angiographic technique and targeted the lesion, and one can inject the microspheres in a targeted manner, not an extrahepatic deposition. If you have not a very well set up angiographic suite and nuclear medicine specialist, this is a very dangerous knife, and this is a very dangerous treatment modality, because if you inject non-intentionally to this microspheres to extrahepatic tissue, for example, stomach, pancreas, duodenum, or gallbladder, the adverse events will be dramatic. But in proper technique, adverse events and discomfort of the patient, very well.
Thank you. Any systemic adverse events as medullary or renal?
No. It's a local. It's a purely local treatment.
Okay, thank you. And I saw on your slides for one patient, did you use capecitabine?
Yes. Yes.
Why capecitabine for this patient?
We are working together with Dr. Esat behind you. He's a medical oncologist. In cholangiocarcinoma patients...
It was cholangiocarcinoma.
Yes, cholangiocarcinoma. Okay. No, not only cholangiocarcinoma. In cholangiocarcinoma and HCC, please, Dr. Esat, say something about this, or I can say it. Okay. In HCC, we sometimes combine radioembolization with sorafenib or capecitabine.
Okay.
And in cholangiocarcinoma, we always combine chemotherapy and radioembolization. We always.
Anti-angiogenic. Yes, thank you.
Another question. Thank you. Last question, please. Thank you.
Thank you. I imagine that before the radioembolization, you perform a technetium-99 shunt scan to evaluate the shunt fraction to the lung, or do you do that?
Of course.
You do that, okay.
Of course. My colleague, Dr. Junaid, is our nuclear medicine specialist. Maybe he can answer your question.
No, but the question is purely interventional radiologist. During that shunt scan, do you coil certain arteries on a regular basis, like the right gastric artery, the GDA, or even the cystic artery if you're in the right lobe? Or do you just try to go super selectively and you leave these arteries open?
If we can, we try super selective and pass the cystic artery or any other gastric extrahepatic artery. If we can't pass, in front of us there is an extrahepatic artery. Except cystic artery, we occlude them in the MAS session, before Y90 radioembolization. But in cystic artery, we occlude the cystic artery just before the Y90 injection, because we saw many patients that if we occlude a cystic artery before radioembolization, after 1 week, when we are doing radioembolization, there will be so much collateral flow to the gallbladder from the right hepatic artery branches.
Mm-hmm. And how do you occlude it? Always with coils, or do you use gel foam or something
always
else?
With coils. We are so familiar with histoacryl embolization, but we didn't use it for any complication. We always use coils.
Okay, thank you.
Thank you so much.